video on clinical case discussion in ophthalmology. Today we are going to show you some cases. The first case is anterior segment patient with corneal ulcer. We're going to show you the history. This patient was a 69-year-old male who presented with pain since 1 month and right post-buckling pars plana vitrectomy oil with ACIUL. He had initial cataract surgery done in another city. So on his last visit, his visual acuity was minus 1.75 severe with a -2 cylinder at 90, and his vision was 660. And he had actually had a recent removal of corneal suture, and he came with a large epithelial defect which was 8 millimeter in size with punctate keratitis. Other examination, which was probably old findings, are written here: that he had an ACIUL, he had total silicone oil removal before, and he had a large cup to disc ratio and he had an inferior band with a 360 barrier laser applied before, and he had an intraocular pressure of 13 millimeters of mercury. So those are the findings before he developed a corneal epithelial defect. At that time, we had initially given him moxifloxacin 1 hourly, tobramycin eye ointment, antiviral, acyclovir 3 times a day, and he was already using alphagan 2 times a day and Sinigan, which is timoptol, and torzolamide twice a day. And we'll see on his examination that the lid is swollen, and he's pretty distressed with it, and he complains a lot of photophobia. There's difficulty in even opening his eyelids. Here you can see there's a central large corneal epithelial defect. These are punctate areas of keratitis which are present on the anterior stroma where the epithelium is not present, and this is an area where there is infiltration on the endothelium, which is called an endothelial plaque. So he's complaining of epiphora. So what you need to do is do a diffuse elimination, reduce the intensity of light just to have a look, and then to do an advanced slit lamp examination. You can see his lid margins looks a bit irregular, signs of chronic blepharitis, and you have to be careful opening the eyelids in these patients because they are really tender. So initially, whenever you want to look at the cornea, you need to have your slit beam at a higher magnification to increase the illumination according to the photophobia of the patient. But the patient, let's have a look. So this is present all in the anterior cornea. These multiple dots which you see are present in the endothelium, in the anterior stroma. And whenever you make a slit, you tend to turn the slit to one side and the other, and then you need to see which part of the slit shows you the pathology. So the epithelial defect, usually corneal ulcers, would start from the periphery, meaning the host and the bacterial fight is going to be at the margin where the epithelial defect is. So there you can see this is the area where the fight is, but usually in fungal keratitis you would get the fungus to actually go through the stroma into the endothelium and produce proliferation over there. So that tends to sequestrate it from the medication which you're using. Usually fungal keratitis also produces satellite lesions, but we did not see the satellite lesion in this patient. we did was we gave him an intracameral fungizone 0.05 milligram and Fortum and vancomycin 2 milligram, and also intrastromal fungizone injection of the same concentration. So his problem was that he's complaining of a lot of pain in his eye, which is not going down. So the sign of any resolution of corneal ulcer is reduction of pain initially. What you need to do is to scraping of the cornea, which we've sent for examination. And then once we have a culture of the type of fungus, we can probably better treat the patient. But at the moment, what we started off was, because he could not tolerate the topical fungizone or amphotericin B, we changed to voriconazole 1.5 milligram 3 times a day. And we continued using the antiviral and the anti-glaucoma along with the antibiotics, and we changed to atropine for the cycloplegic agent. So important thing to remember in these cases is you need to see where the lesion is and then to see serial response of the patient. So with this patient, you would ask the patient what his complaint is, and his main complaint is a lot of pain, and which is not getting better. So you need to reevaluate your examination. And I think what I found is taking serial pictures of the patient usually gives you a good overview of how things are progressing. So this is just a cut section of what you saw in this patient's history. But considering this, clinically it looks like a fungal keratitis because of the formation of endothelial plaque. We suspect that the treatment will last at least a couple of months, but it has been shown that using intrastromal and intracameral antibiotics in these kind of patients is very essential. Otherwise, the usual sequel of this treatment is, if they are left untreated, they would have corneal perforation and endophthalmitis. So whenever you see such a patient, clinically judge what it is, especially ulcers which are non-responding to treatment, because those are the most challenging cases in corneal infections. So identify those cases and modify your treatment and give them the broadest spectrum of antibiotics. Diflucane is a topical antifungal, but it's usually localized towards Canada, while Fusarium is the most common organism which causes fungal keratitis around the world. And what we think what happened was he initially developed an epithelial defect that exposed the corneal surface. He had a non-healing corneal epithelial defect of unknown etiology, which exposed him to keratitis, and initially thought he might have geographic keratitis associated with herpes, but as soon as he developed those endothelial plaque, we changed the form of treatment and started treating him very aggressively. And the decision to change over to intrastromal and intracameral antibiotics is very essential. If you do not have a good view, you can also augment with a B-scan ultrasound. So I hope you have had a good overview of what happens in a fungal corneal ulcer and what are your options available and how you should strategize your treatment to help the patient most effectively. Thank you very much.